Okay. All right, Assalamu alaikum. So we'll get started. I hope everybody had a good lunch break. Our next speaker will be Dr. Hamza Lari, who is an interventional MSK and pain management specialist, and he'll be talking to us about interventional MSK injections around the shoulder. Dr. Hamza Lari.
Thank you so much for the introduction. So we're going to have a quick talk about shoulder intervention procedures that we usually do in our clinic. So we're going to reach to talk about basic injections and a little bit more advanced at the end of the talk. And we cannot cover everything, but we'll try our best. So if you like AC joint bursa injections, sorry. And calcific barbotage, as Dr. Ahmed talked, and some like nerve blocks and shoulder denervation with some few cases at the end. Okay, so patient selection is very important to consider while you give injection. So we know there's so many different types of injection, and basically there is like anabolic, catabolic, there is like prolotherapy, there is hyaluronic acid, PRPs, Botox for some cases that we use, and one of the cases I will discuss. Now for shoulder, intervention suites have a couple of modalities, CTs, C-arms or fluoroscopy or angio, and you have the ultrasound. Mainly we're dealing with soft tissue, so basically I'm going to talk about ultrasound injections. So the shoulder is a kind of, a location where you have like three main joints: the SC joint, the AC joint, and the glenohumeral from the front. And there's a false joint, which is the scapho-thoracic joint. Consider it as a false injection. Also, for some cases, I didn't cover this slide, but RF for a few cases, I will discuss it in the end. To start with the AC joint, so we basically just put the probe on the coronal view of the AC joint, and basically we're going to see the cortex in each side of the acromion and the clavicle. You will see if there's any ossified. You can do dynamic like assessment. You can push the clavicle at one end and see if there's instability. In this case, we don't prefer like AC catabolic or steroid injection. Now you see the tip of the needle is here. This is because we're going out of plane. There's two ways to go through that, which is out of plane. So the probe is here, the green stuff, and then you go on the side of the probe. And there's in plane. I do personally like out of plane because you easily go inside the joint and you're inside definitely. There's a couple of techniques in the literature going in the AC joint, going then deeper to the subacromium and then going in the glenohumeral. I don't do that, but it's described. Again, in the ultrasound, you can do the beauty of it, like you can see the ossified, you see the hypertrophy, you see a couple of stuff. If you go in plane, it's very difficult to reach inside the joint itself. Subacromial, subdeltoid, very easy to do. You can again assess before you do any injection. You can see the bursa, will see the thickness. There's a variety of indications. I'm not going to go through it, it will take time. But the nice thing is that when you inject, you will see that the flow is not really going intramuscular or intratendinous in the supraspinatus. You will see the spread of your cortisone, for example, in this diagram that is inside within. Sometime the widening of the bursa will happen, which is like the exact stuff that you need to see between the two lines of the supra and the deltoid above it. The other injection is long-headed biceps injection. We've been asked many times by shoulder doctors to do the long-headed biceps injection. Now we know that the proximal part is continuous within the joint, so that's what exactly we do. That when we inject in the proximal long-headed biceps, we're injecting actually intra-articular. We don't do it a little bit distal because it's going to be like tendinous or musculus injection, which we don't prefer. Now there's a small circumferential artery you have to avoid before you inject. And it's nicely seen in this diagram. You see like there's a small artery you need to avoid because it's the steroid is particulated medication, you don't want to embolize anything if you see any vascular structure. The glenohumeral, there are different approach, the posterior and the anterior. It's always safer and better if you're doing a diagnostic therapeutic or any injection to go in the posterior, which is like beneath the scapula spine, and you will see it very nicely. You can go medial to lateral, which is in this diagram, or lateral to medial. It doesn't matter. Just like see whatever you like. The main thing is that to avoid the labrum, because it's very innervated, you have to be away from that. That's just a diagram just to see the particulated steroid within the glenohumeral, and this is lateral to medial. Now, mainly the indication is for adhesive capsulitis or frozen shoulder. The key stuff that to really confirm it. I know it's a clinical diagnosis, but the nice thing that you can see is like enhancement of the bicipital interval, and you can see also the inferior which is like also confirming the diagnosis in those pictures. Now, one of the nicest things that we can do with ultrasound is to do hydrodilatation. So you can see that the needle's coming from medial to lateral on the humeral head. You can see the dilatation, and you can feel the pressure while you're injecting, and you will feel sometime the rupture or capsule rupture after the end of your injection. Now, there's little evidence on whether the capsule rupture that achieved as a goal for successful treatment of adhesive capsulitis or not, but it has been described. There's a couple of articles in the literature describing that if you actually do capsule rupture, a few of the studies here describing it, there will be a little bit of superiority for capsule rupture and hydrodilatation versus just a glenohumeral steroid injection. And then there's like many studies in short and long terms describing mainly the same, from moderate to severe pre-injection pain control to no pain or mild pain. And this is describing the same thing, but with a range of motion in different directions. Okay, so the anterior part, I've seen many people do it like out of plane in the bicipital interval, but I'd like to avoid it because there's lots of stuff in between, and especially if you're doing arthrograms and you go anteriorly, you may inject a little bit of contrast within this area, and it's going to misinterpret it in the MRI or CT, so it's going to give you false reading. Sometimes you will describe like superior labral tear or whatever tear. And this is actually, we do it a little bit superior than this picture. You can see the filling of the glenohumeral interarticular space with the proximal part of the long head of biceps. Now, going to the fifth type procedure I described here is calcific barbotage, as Dr. Ahmed was speaking, really good presentation. Now, the key is that it's really very easy to see those on ultrasound rather than to compare it with small calcification in MRI. Easily can be missed. Now, even bigger calcification can be missed. Sometimes it's very nice if you see the calcification on X-ray, but if it's overlying the humeral cortex, it's going to be so much difficult, especially with the small ones. And then if you compare it with ultrasound, you will see how nice and easy you can pick those even small tiny stuffs of calcification, and you can see the hidden and posterior part of the infraspinatus. There's a lot of like incidents I've seen calcification, and the patient cannot have a proper management because of that. Now, this is an easier one. You can see the low intensity calcification, and you see the same one, bigger one in the ultrasound. There's as Dr. Ahmed explained, there's different stages of the formative, resting, and resorptive phases. Both of them you will see. The morphology is a little bit different, and the symptoms will be more severe when you go more across the stages. The sonographic appearance will be also a little bit different. There's more vascularity as the patient is more symptomatic, and the resting is more fading, and then cystic appearance in the resorptive phase. Now, this is just, kind of a typical mouth we described as a as a fish mouth opening while you're injecting. It's a one injection technique, or one needle. And you will find it very satisfying when you see that the calcium is coming out while you barbotage. So that was like one of the few, largest case. We took a lot of calcium out, and you can see the resorptive and the cloudy appearance of the liquid here. That's another case with actually a very large amount of calcium taken out, and it's a one needle technique again. So this is one of the biggest calcification. It's very satisfying when you see those. Now the calcification can happen anywhere in the upper lower limb. This is one of the rectus femoris, proximal rectus femoris calcification. And this is, again, the calcification seen here. This case was treated with a couple of barbotage and PRP, and he had final resolution. In this case, you probably in the, next picture, you will see that the calcification is getting less with more injections. This is the distal biceps femoris calcification seen very nicely here. Now, going back to the glenohumeral injection, sometimes for frozen shoulder, we do suprascapular nerve block, which can be beneficial for frozen shoulder, can be beneficial for patient contraindicated to do any operations, like severe degenerative OA, or many other indications where the patient cannot do any operation, and the good thing is that you de-innervate the suprascapular nerve, which is innervate a large portion of the posterior medial and a little bit posterior lateral of the part of the glenohumeral and the AC joint. So the way to do it is just to probe the probe of the superior margins of the scapula, and you will see that more indication like CRPS and hand-shoulder syndrome, which is less likely to be seen. When you put the probe from medial to lateral, you will see that the transverse ligament here and the artery above within this, and then the suprascapular nerve below it. This is the trapezius and the supraspinatus. So you can go medial lateral, you can go out of plane. It's always to the best of the physician, where he feels more comfortable and easily to avoid the artery, which is here is like lateral to medial. And many physician has described it in the literature to go fluoroscopic guidance, like this picture. So there is a couple of studies. One of them is like a few of them showing the follow-up up to 1 and 2 years, the maximum benefit after 3 months, and gradually going less with time. And if you combine it with intra-articulate, a little bit of not very significant improvement. So sometimes it's always good to do just nerve block and to combine it with pulse radiofrequency. Now, shoulder denervation, kind of a new intervention has been described. So they do it for like non-operable cases with the radiofrequency ablation for 3 main branches, including posteriorly the branches of the suprascapular nerve. After it rebranches only the sensory fibers in the sphenoglenoid notch, and anteriorly the branches of the lateral pectoral nerve, and also the lateral branches of the anterior axillary nerves. So this is exactly how you see it in fluoroscopy have been described. It's very difficult to see like very tiny small nerves in ultrasound. This is a nice neurography, showing all those small nerves in one of the articles. Now, a few cases like, we always see in our clinic that there is
2 minutes.
Yeah. So we always see in our clinic like neck, shoulder, radiculopathy. It could be neck, it could be shoulder, but sometimes we de-estimate the the chance of neurogenic transthoracic outlet syndrome, which can also be one of the options as a non-surgical intervention procedure, have been described in the literature to do Botox injection within the interscalene or the pectoralis minor. So this is one of the study with the one of them was 5 years of follow-up, and it had actually a good result with no or like zero side effects if you do it properly. So this is the interscalene, you can put it here. This is the pec minor, the pec major is above it, and this is the exact injection going from superior caudal to superior cephalic to caudal, I mean. And this is the interscalene with the brachial plexus in between. So that's another case at the end, which is describing the like chronic shoulder pain with osteodystomas. The figure of 8 is nice in the chromium, and we do the radio frequency CT guided. Thank you.
Thank you, Dr. Hamza, for this comprehensive review. Does anyone have a question? We can take 1 or 2 questions. Okay, so if not, I just have a comment. Please, if you have a patient with a shoulder pain and you don't know what's the diagnosis, or if you're not sure how to inject, don't inject in the clinic blindly. You can send them to, we have a lot of musculoskeletal interventional radiologists, very competent radiologists. They can help you with the diagnosis and they can inject accurately. Because for the patient, they will consider this is a failed attempt if you do it in the clinic. I tried injection and it failed. But it's not as effective maybe if they do it in the proper way. Thank you, Dr. Hamza.
Thank you.
So our next speaker is Dr. Ali Diab. Dr. Ali Diab is an associate professor in Faculty of Medicine, Department of Epidemiology and Community Medicine. And he obtained his MS degree in genetic epidemiology from Washington University, St. Louis, 2006. And then he got his PhD in epidemiology from University of South Carolina, 2014. He published more than 55 articles in peer-reviewed, high-quality journals. Dr. Ali Diab, please welcome, and he will talk about how to conduct a clinical research.
This is next, this is the whole thing.
Thank you, Dr. Ali. I'm pleased to be here. This is a shifting gears from intense surgical procedures into more, I guess, the most entertained subject by physicians, epidemiology and community medicine. So the question or the topic we have in hand is how to start a clinical research. So clinical research usually guide clinical practice. So evidence-based medicine is the topic. Stratified medicine, precision medicine is the topic in hand for physicians. So it's a brief talk just on some guidelines on how to do or how to start a research project. So clinical research is any research activity that involves the humans, tissues, samples from human participants or subjects that aim to basically understand health and disease. And the overall idea or the overall objective is to better identify, diagnose, treat, and best if we can prevent disease. In my talk, I'll be talking about 7 components that we need to consider before starting any type of a clinical research. So the first of the 7 components is the research question and its significance. So at the early stages of any type of research study, we need to define the research question or questions as clearly as possible, considering what is the main outcome that we want to study, what is the exposure of interest, and what is the population we would like to basically answer our question based on. So there is a framework called the PICO framework. So it's the population, exposure, intervention, and comparison group. So we need to consider the PICO framework when framing our question. The second, okay, so we're doing a clinical research, we're doing a research. What is the significance? You need to convince either the peer reviewers or the people who will provide the grant for the research. Is this a significant research? Clinically, are we addressing any knowledge gap? How it will improve patient care, treatments, physician practice. So the first component, we need to identify a question of interest and also what is the significance of the research that you'd like to do. The second step, you need to think about the measurements. You have the outcome variable, so how you will ascertain the outcome. Is it through x-rays? Is it through clinical assessment? Is it through questionnaires, some biological markers? So you need to think carefully about your outcome variable. What we need to have a clear definition of the outcome, so the group of cases you have are not a heterogeneous group, rather they're more of a homogeneous group of patients. So you need to have a clear definition of the outcome variable. Do you have a main exposure of interest? A main intervention that you would like to assess or evaluate, and how you will assess your exposure variable. And third, there are something called confounding variables. So those are third type of variables. In definition, they are associated with the health outcome and at the same time related to the exposure you would like to study. And failure to account for confounding variables, usually in epidemiology or clinical studies, will lead to biased estimates of associations, or will lead to wrong conclusions about the relationship between the exposure and the outcome. So 3 things we need to keep in mind when planning. We need to define the outcome or have a working definition of our outcome variable, exposure variables, and confounding variables. Next, we need to select the best epidemiological design that will help us answer the research question in the best way possible. So we need to choose the most appropriate epidemiological design, and also who will be the study subjects. Are they patients from a single clinic, from multiple clinics, or do we want to enroll people from the community and do an interventional study? So we need to think about the design and the participant. And usually the study design is influenced mainly by 2 factors. The research question of interest and the feasibility and constraints. For example, if the outcome that you want to study is a very rare outcome, so it's not a common outcome, then we are guided more or less toward a case control study where you will be selecting the cases into your study, so you will handpick the cases. But if the outcome or the disease you're studying is a very common disease, maybe you can go to the community and identify enough number of cases. The exposure, rare, common, again. If it is observed exposure or it's an assigned exposure, what I mean by an assigned exposure in clinical trials, the investigators, they do assign the exposure to a group of people and a placebo to another group. So if you have the exposure you want to test or experiment something, then you're guided toward an RCT, a randomized trial. And the measure of frequency. Are we measuring incidence or prevalence? I'll come to that in a later slide. Feasibility constraints. Do we have access to the target population? Do we have access to the patients? And the logistics and resources. Do we have enough logistics, resources to help in conducting the research forward? So I will focus mainly on those 4 main epidemiological designs. You can think about epidemiological designs either as observational, where the investigators will only observe what is happening to the patients or what's happening in the community, or experimental, where investigators, researchers, they do some experiments with the human subjects. They assign them either to physical activity, no physical activity, surgical procedure, different surgical procedure, and to observe the differences over time. Just briefly, cohort studies are observational in design. The investigator enrolls a group of people, determine who is exposed, who is not exposed, do a follow-up in time to determine what happens. Either they develop the disease, or they go into remission, or it's the reoccurrence of disease. So it's a longitudinal type of cohort study where you have a follow-up period. Case control studies is different than cohort studies. The enrollment in the study depends on disease status. So the investigator, if it is a rare disease, then the most appropriate design is to do a case control study, where the physicians, the investigators, will handpick the cases into the study and will have another comparison group, a group without the disease, for comparison, what we call the controls. And the premise of case control study, if there is an association, then we would expect that the exposure to be more common in the cases in comparison to the control groups. So case control study was developed for very rare type of diseases where we don't have enough number of cases in the community to enroll cases from community, so cases are chosen from the clinics. Cross-sectional studies are also observational studies. They're more simple and basic design, usually also called the prevalence studies. They're used to determine the extent or the burden of disease in a given community. If we want to assess how many of my community or patient group have this type of outcome or have this another type of exposure, how many are smokers, how many are physically inactive. So you can do type of cross-sectional studies. So we have a defined population, both if you have an exposure or a risk factor and an outcome are assessed at the same time. And the gold standard or the best evidence can be obtained from randomized clinical trials, which are mainly used to assess the effect or the efficacy of treatment or prevention measures aiming at curing, controlling, or preventing the occurrence of disease. And the element here, we have the element in RCTs, we have what we call random assignment or randomization. So this is what makes basically RCTs the gold standard because of randomization. We create two comparison groups, a group taking, for example, a new treatment, undergoing a new procedure in comparison to an existing procedure. So the randomization will create two groups equal in all characteristics, known characteristics, unknown characteristics. The only difference will be between the two groups, in principle, in essence, is basically the treatments. A group receiving a treatment, a group not receiving a treatment. And therefore, any evidence we get from a very well-conducted RCT should be the best evidence available in the literature to us. A fourth component, when talking about designing research studies, is to think about, okay, am I measuring incidence of disease or reoccurrence of a disease, or am assessing the prevalence of disease? So those are two simple concepts in epidemiology. When we talk about incidence of a disease, we're talking about the new occurrence of disease. You have somebody without the outcome of interest, you follow them up for 5 or 6 years, and then somebody develops the disease. This is an incident. A prevalence means the existing cases of a disease in the community, and the relationship between incidence and prevalence is the pool of patients that are existing in the community. Incidents are the newcomers into the pool of prevalence. So also the type of measurement you would like to measure in your study will influence the study design you will choose. For example, cross-sectional studies are not designed to assess incidence. They're designed to assess the prevalence. Cohort study can help in assessing the incidence of disease. Then we move into what type of effect measurement you want to study or you want to evaluate in your study. Effect measurement, again, it's another name, is measures of associations. For instance, odds ratios. I think if you read any article, there is an odds ratio, relative risk, hazard rate. So what type of measurement we want to assess? And that's used to basically determine if there is an association between the exposure we want to study and the outcome. And if there is an association, how big or how large the effect is. Is the odds ratio 10? Is the odds ratio 1, which means no association? Or is the odds ratio 4? So we need to have an understanding, is there is an association? So association by definition means that we have two variables that are associated, meaning that if one variable changes, the other variable change. If one increases, the other decreases, and so on. So in principle, if there is association between exposure and disease, then we will expect that the prevalence or the amount of disease in the exposed to be much higher than the amount of disease among the unexposed. Okay, so we move to the next slide. Then you need to think about what are the sources of error or the sources of bias that can basically hamper your research findings. So we always, in clinical studies, we always strive to have a valid estimate of association. So we want to say we are confident that the measure of effect in the clinical trial is a valid measure of effect, and we see a reduction of 30%. If we do the new procedure in comparison to the existing procedure, we will reduce the burden of disease by 30, 20, 50%. So we need to have a valid assessment. So threats to validity in any research or clinical research can be thought of as selection bias, information bias, and confounding. Selection bias involves the manner in which you enroll subjects into your study. Did you focus on subjects who have severe disease and have higher levels of exposure? Then those subjects are not represented, they don't represent the pool of patients. When we talk about information bias, did we have any type of measurement error when we assessed the disease or when we assess the exposure that we are studying? So there is something called misclassification. Maybe someone who's not exposed mistakenly being said that they're exposed and so on. And then there is confounding. So failure to account for confounding again can lead to serious error and wrong conclusions. And the last component is the statistical issues. So three things. We need to state hypothesis. So a null hypothesis will always say that there is no effect of the intervention on the outcome. An alternative hypothesis will say that we have, there is an effect. And sample size. So this is the magic, I think. Most of the time we see people choosing, okay, we're doing a study. I will have 20 patients in the active arm, another 20 patients in the placebo, and we will do a study. But sample size is very integral, because without a proper sample size calculation, we will not be able to have what we call enough statistical power to say that there is an effect or there is no effect. So sample size need to be determined before the start of the study. Otherwise, toward the end of the study, if you have what we call an underpowered study, your results will not have strong meaning. And the analytical approach. So at the beginning, at the designing a study, you need to think about what type of a statistical test you will be using. Is it survival analysis, logistic, linear regression, and so on. So 7 steps, I think of them always whenever we think about any type of a new research, clinical research. Those are the steps we go through. We try to refute and basically go through all of them, have them filled into a sheet or 2 sheets just to brainstorm. So thank you all for allowing an epidemiologist to be here between you today. It's a brief introduction on how to do clinical research. Thank you.
Thank you, Dr. Ali. Any question for Dr. Ali? Okay, so if not, we thank you, Dr. Ali, for your talk, and we'll move on to our next speaker, Dr. Hassan Bahbahani. Dr. Hassan Bahbahani is a pain and anesthesiologist from Jaber Al-Ahmed Hospital. He is a graduate from MD National University of Ireland, and he did his residency from Western University from University of Toronto, and he works in Jaber and Dar al-Shifa, and we refer to him our patient most of the time. He will talk to us today about the role of regional anesthesia in orthopedics when we do regional compared to general anesthesia.
Okay, good afternoon, everybody. I'm very happy to be here today to present a talk on regional anesthesia for orthopedic surgery. As mentioned by Dr. Ali, we work together in Jaber Hospital. We have, I think, 3 or 4 dedicated ortho rooms, and we're slowly trying to introduce regional anesthesia. So being an alien here, I'll just have a quick introduction to what's our role as anesthesiologists. So first, we have to optimize patients for surgery, both physically and mentally. We're considered facilitators. Our main goal is to have the whole team, the surgeon, the nurse, and us, as well as the patient, working together for the best outcome. Usually facilitators must remain neutral, and they remain neutral to both the surgeon and the patient and themselves in order to have the best outcome. This is in contrast to what some surgeons believe, including my uncle, who's a professor in surgery, that our task is confined to raising the table up and down. It's much more than that, but we have to get some slack from surgeons, that's okay. So we can provide anesthesia in very different ways, general, neuroaxial, and regional, as well as sedation, which is usually combined. There are many issues with each one of them. So with general anesthesia, you have vomiting, increased risk of nausea and vomiting, delayed emergence, may delay your second case. And then in ambulatory settings, especially with long-term medications or long-acting medication, it may delay it. With neuroaxial, we're having an elderly population. Many of them are anticoagulants or have coagulopathy disease. There's issue with ambulation immediately, especially with the new techniques for TKR and total hip replacements. And then if we're using morphine, there's risk of urinary retention. And then there's the issue of monitoring a patient with epidural. And then if you're doing a TKR on one knee, why should we block both knees, correct? So we have to focus on blocking the specific leg we want to operate on. And then there's regional anesthesia, which is the center of our talk today, which can be done as a single shot and as well as catheter. And now there's a new technique where a patient gets like a small baby bottle with medications and he goes home the same day. And then sedation combined with regional, patient can be deeply sedated, not moving at all, with a very good adequate block. So why regional anesthesia? So I'm very biased. I think regional anesthesia should be used whenever possible. If you go to the literature, there's no difference in terms of morbidity, mortality. There was talks about less DVT and less bleeding. Even that, with the new medication, general anesthesia provides similar outcomes. But the major difference applies to ortho. So you get decreased PACU stay, less nausea, vomiting, immediate ambulation post-operatively, especially with new techniques that have muscle sparing. And then you have reduced nausea and vomiting as well, as I mentioned, and early return of activity of daily livings. However, despite all of this, this data is old, from 15 years ago or so, and on the left is the peripheral nerve blocks, and on the right, neuroaxial, which include epidural and spinal. Only 25% of procedures were done under these techniques. I think from 2006 until now, we've moved significantly forward, but it's still a low number, if you ask me, especially when we've seen all of these results. So why? This is one of the studies done in the University of Toronto in 2004. And basically they did a survey on orthopedic surgeons, the attitude and knowledge regarding regional anesthesia. And they've asked them two questions. The first question is, would you recommend a regional anesthesia technique for a patient who's coming to you for a shoulder arthroscopy or an ACL repair? 30% only would recommend that to the patients. However, when the question was changed to the surgeon and said, would you yourself have a regional anesthesia technique if you were having a shoulder arthroscopy or an ACL repair, 53% of surgeons said they would have it on themselves, which was 0.06, statistically significant. So why is there resistance to regional anesthesia? Many times it's a valid resistance, and somewhat, because time is money. And if you don't have a dedicated block room, a dedicated team to provide adequate regional anesthesia, and the block must work. If the block is not working, the surgeon, he might trust you one, the second time, the third time, he's going to say, I don't want the block anymore. So time is money. The other reason, there has to be a balance between pain control and mobility. If the patient has a dead leg post-operatively and is not able to mobilize, especially with what we know with physical therapy immediately, and patients are loving moving afterwards, these blocks are not going to be reasonable. The other issue is falls. Many of these blocks, especially the femoral nerve block, will cause quad weakness. And although the data is equivalent, but these patients can fall, and that's not a good outcome. We know that, at least in the USA, by 2026, more than 50% of all cases will be done in ambulatory settings. And in order to facilitate this and achieve this, we have to provide techniques that are considered ambulatory, that these patients can go home the same day. So this starts by us, anesthesia, providing an adequate block room, a well-designated area with emergency equipment available, added safety. We have to have a place where we can have enough soak time. Soak time means that when I do the block is not going to work miraculously within 1 minute. It will take 25 to 30 minutes to work. We need that time. How do you do this time management? We bring the patient early on. So if the case starts at 7:30, we have to bring the patient early on at 7 or 6:30 a.m. It's very hard to sell this to some anesthesiologists, but I'm trying. And do the block, and then the patient goes to the OR ready to be either put asleep as the general or deep sedation. It also can facilitate the next second or third case. You can communicate with the surgeon intraoperatively. When are you going to finish the case? Or I have 45 minutes left. You block the patient, and so on. This will actually be faster than a general anesthetic with excellent pain outcomes. A very good example of where regional anesthesia has worked is total knee replacement. Total knee replacement, in the past, patient used to stay in the hospital for 4 to 5 days. The technique was a femoral nerve catheter, a sciatic nerve catheter, and an obturator nerve block. This has significantly changed, and now we're doing same-day knees. I'm not sure if it's happening yet in this region, but it's very well known to discharge patient on the same day. The knee is richly innervated by, you can see here, the saphenous, so it has branches. The blue ones are from the femoral nerve, and the yellow ones are from the sciatic nerve. And then you have small branches, which is the genicular nerves. Supramedial, inframedial, and supralateral are the one we block. We usually avoid the infralateral genicular nerve. Lateral genicular nerve, because we want to avoid blocking the peroneal nerve and avoid a foot drop. The way to think of it, moving away from a femoral and sciatic nerve all the way to 3 combined nerve blocks is just like in the past. We used to give patients whole blood, which has excellent products, but also had white blood cell counts. So you get the bad reactions that we don't want. And now we focused on component therapy. The same thing with regional. We're going to give a good block that provides excellent pain relief, but is motor sparing. And in total knee replacements, we can do that with blocking the 3 nerves, the adductor canal, and the IPAC, which is the interspace between the popliteal artery and the capsule of the knee, and then the genicular nerves. And you can see from the yellow diagram, all these are from the mid-thigh to just below the knee. So it's excellent for motor sparing. So I'll quickly talk about them. The adductor canal is basically you're blocking the saphenous nerve, which is a branch of the femoral nerve, in the adductor canal. It is as equivalent as blocking the femoral nerve, but without almost no quad weakness at all. The only issue with it is sometimes you miss the nerve to vastus medialis, and that's why if you only block the adductor canal, you only have 50% chance of getting an excellent block post-operatively. And you can see the saphenous vein can be blocked, but sometimes you miss the nerves to vastus medialis. And then the IPAC, which is the interspace between the popliteal artery and the capsule. And then the third one, which is very important and very quickly done, which is the genicular nerve. This can be done intraoperatively or in patients with chronic osteoarthritis with radiofrequency ablations as well. This block, in a study in Duke University, where they compared the use of bupivacaine with dexamethasone based saline, and in the control group in the post-op day 1, they had 60% less opioid use compared to sham, and then 48% compared to the saline group. What's very lovely about these blocks, this block literally takes 1 minute. There's a video on YouTube, 1 minute and 20 seconds to do this block. And the other 2 blocks don't take long as well. So it's all about time management. Finally, what do I think about local infiltration? I love orthopedicians, and I think sometimes these are an excellent block, but my issue with local infiltration is 2 things. Reliability is the main one, and reproducibility. It's not a standardized technique. You're basically blocking areas in the posterior capsule. The third important thing is there are still arteries at the posterior capsule, so when you're blocking blindly, there's some arteries that can be blocked, and you get a lot of medications, a huge volume of local anesthetic, then you get local anesthetic toxicity. So to recap, that's what we're doing in Jabr. In some cases, basically we do the 3 blocks before going to the OR, either with a spinal anesthesia or general anesthesia. Intraoperatively, if it's spinal anesthesia, we'll do a propofol sedation, deep sedation, make sure the patient doesn't move, so the surgeon is also happy. And postoperatively, you still need sometimes pain meds on as need. Like the patient cannot be without any pain meds, just in case. And so in summary, the nervation is complex with 10 separate branches. However, with a good motor sparing blocks, we could have excellent safety and efficacy. Thank you very much.
Thank you, Dr. Hassan. Any question for Dr. Hassan? Role of regional anesthesia? Yes, Dr. Abdullah? Here.
Thank you, Dr. Hassan. What about the pain from tourniquet? How to control the pain from tourniquet?
So the pain from tourniquet depends. If you're doing a upper limb block, a quick local infiltration can cover that easily. If it's a lower limb block, then usually the tourniquet pain is gone. It's covered with the femoral nerve block.
Now with your knee block, you are blocking distal to the tourniquet.
Oh, you mean with if you can use the tourniquet for the knee replacement?
Yeah.
I would just do a general anesthesia.
Yeah, good.
Yeah.
Thank you.
The main goal for the knee blocks is pain control. It's not going to provide anesthesia. You either have to have a spinal done or a general anesthesia done. But with the arm, then you have to do the infiltration. Okay? Thank you very much.
Okay, we'll move on to the next speaker is Dr. Yusuf Marwan. Dr. Yusuf Marwan is Assistant Professor of Orthopedic Surgery at Kuwait University. He did his MD degree in Kuwait University. He did his residency in McGill University. Then he did 3 fellowships in sport and in adult and pediatric deformity reconstruction. And he specialized in bone defect and bone infection and knee arthroscopy. So today, Dr. Yusuf will talk about the role of osteotomy in patients with patellar instability.
All right. I'm going to talk about unusual approach for patellar instability to a lot of us. Okay, so if a patient presents to you in your clinic with patellar instability or even patellofemoral pain syndrome, how would you examine the patient? I just want to know, do you do rotational profile examination? Do you examine the patient prone? No one? Okay, good. All right, so this is how we assess the patients. Any patient with patellofemoral issues, all right? So we look at the patient standing. If you see here with the foot facing forward, the patella actually are looking at each other. That's kissing patella. There is, just by this, there is a rotational problem. When you place the patella forward, you see there is out-towing. Then you see the patient walking. You see what we call foot progression angle, which is basically are they in-towing or out-towing. Then you do hip range of motion, very basic medical student level physical examination, hip range of motion, internal and external rotation. And you do something called foot thigh axis. So this is an example of a patient. The picture on the left is the maximum external rotation she can do. She has patellofemoral pain. And the picture in the middle is how much internal rotation she can do. And this is basically demonstrating this actively. So torsional problems can cause many issues. It can be at the femur or at the tibia level. For the sake of this talk, we're going to focus on patellar instability and anterior knee pain. Don't forget to assess hip range of motion. If there is increased internal rotation and decreased external rotation, you should think of excessive femoral anteversion, like in this case, and this case as well. This is the other way around, excessive femoral retroversion, and you look at the thigh-foot axis, as we said, all right? I'm going to demonstrate some cases. Then we can also assess radiologically with a rotational profile. We measure the relationship in the axial plane between the proximal femur to the distal femur and the proximal tibia to the distal tibia. This is not something that we use to help in decision-making for treatment. This is just to validate our physical examination finding. I'm just going to show some cases. Okay, so this is a 40-year-old female who plays karate, very active. She's been having patellofemoral instability in one side, on the right side, and she had what is very commonly done by our senior surgeons here, VMO plication and arthroscopy, and she's been still suffering from the same problem. She has, on the right side, she has internal rotation of the hip of 80 degrees and external rotation of 20 degrees, and on the left side, it's a normal hip range of motion. Normal mechanical axis, you should always consider in patellar instability. She has normal mechanical axis. We do rotational profile, it validates our physical examination. There is increased femoral anteversion on the right side, and the tibia torsion is normal, all right? We also measure TTTG distance, the distance between the trochlear groove to the tibial tubercle and the axial plane. And for this patient, we did arthroscopy to check the tracking first. Then we do femur derotation osteotomy. We do some planning before. In this patient, we decided to derotate the femur 15 degrees. So we use a sterile goniometer intraoperatively. We place a wire at the proximal femur and a wire at the distal femur in a 15-degree relationship. Then we move on. We do percutaneous osteotomy with multiple drill holes and osteotome, the Bastiani technique. We do before we do anything, we do drill hole at the predetermined osteotomy site. Then we ream. Then we pull the guide pin back. We continue with drill hole, more drill holes and osteotome. And then we break the femur. This is low heat generation osteotomy instead of using a saw. And this is with a 1 centimeter incision. All right, then we pass our nail and we derotate. We lock the nail on one side, let's say proximal or distal, and then we derotate. The wires become parallel. All right, this is a demonstration, a video demonstration from another case I did. Not the same case, but just to show you what we do. All right, then we lock the other side of the nail. And these are the incisions for this surgery. The middle incision is, this incision is where we do our osteotomy. All right, and this is post-op 2 days. 6 weeks, you see good callus already, and the patient full weight bearing immediately post-op. And she's already gone, she's feeling the pain is gone. Very early post-op, and all the mal-tracking feeling is gone also. She doesn't hear any cracking. That's another case, 18-year-old female with chronic bilateral anterior knee pain and 2 episodes of patellar instability. She has normal hip, but she has abnormal thigh-foot axis, all right? And when she stand normally, the patella facing each other. So she's basically out-toeing. And when we do our validation with CT rotational profile, she has excessive tibia external torsion on one side. Just to show you, this is from my fellowship, not in Kuwait, unfortunately. We do gait analysis for the patients, just so you understand. This helps a lot. And these patients, when you do derotation osteotomies, they actually improve even in their gait analysis and functional scores. Hopefully at some point we do it in Kuwait. So this patient had tibia derotation. This is on the tibia now. Again, we do pre-drill our predetermined osteotomy site. We do rotational marker wires, proximal and distal, away from the nail trajectory or the nail placement. We ream, we pull back, we complete our osteotomy with more drill holes and osteotome. We pass the nail, we lock it one side, we derotate, and we lock it the other side. And the tibia, of course, we have to break the fibula as well to be able to derotate. This is 2 weeks post-op of a derotation osteotomy. Now, this patient is having both hip and tibia rotation problems, although the CT scan is not very suggestive in the femur, but the clinical examination is very suggestive, all right? Internal rotation is 70 degrees, external rotation is 15. So we decided to do both. So this is an example of both: femur derotation, tibia derotation, and fixation. Now, this patient is a 15-year-old female with patellar dislocation as well, patellar instability. She has She has femur rotation on physical examination, but the tibia is normal. Also, CT rotation profile is not very suggestive, but we don't care. She has trochlear dysplasia. The trochlea, the groove is not really a groove, it's actually flat. There are different types, we're not going to talk about them here. So in this patient, we did a femur derotation osteotomy, trochlearoplasty, and MPFR reconstruction with lateral retinacular lengthening. So this is the femur derotation as we explained before. Trochleoplasty, we create a groove for the trochlea, and we do the ligament reconstruction. Another case, this is a patient with showing a good demonstration of a positive J sign here. 16-year-old female, recurrent patellar instability, suffering for many years. She has abnormal hip, femur rotation, and she has borderline actually, because see here, there is increased internal rotation, but there is also not bad increased internal rotation, but not bad external rotation. So these patients could be just like in general, or a little bit hyperlax, like a variant of hyperlaxity. So in this case, if there is no decrease in external rotation, we don't worry much. But the patient clinically has genu valgum. So we do our deformity analysis, and she has an abnormal TTTG as well, or borderline TTTG. Rotation profile is normal. So this patient, we did tibial tubercle transfer osteotomy, medialized the tibial tubercle, distal femur osteotomy, and MPFR reconstruction. So this is where we medialize the tibial tubercle and fix it with 2 screws. And then we do distal femur open wedge osteotomy to correct the valgus. All right? Showing just a few seconds, showing the steps. We put a guide, reference guide. We cut with the saw. We complete the cut with osteotomes. We stack multiple osteotomes. Then we use a laminar spreader to spread, and we check our alignment interpretively. Then we fix with a locking plate. Final fixation with the tibial tubercle transfer and ligament reconstruction. This is a very unique situation here. This is the last case. 29-year-old civil engineer, bilateral recurrent patellar dislocation for at least 3 years, suffering for many time. Okay, so here the physical examination is suggestive of both femur and tibia problems, and also she has abnormal TTGG. So what do we do in this case? We have to transfer the tibial tubercle, and we have to derotate the tibia. So this is a little bit complex situation here. All right, so which is validated here also by CT scan. So this is what we do in this case. So we do the femur derotation, and in the tibia, we do supratubercle derotation osteotomy. We do the osteotomy not low, we do it at the level above the tubercle, and because this is an external torsion, that foot is externally rotated, so when we internally rotate, we will also at the same time medialize the tibial tubercle. And if you see, the approach is very biological for osteotomies. If you're trying to do deformity correction, here we're preserving even the pes tendons. They're above the plate. And the plate is over there, post-op. And you see, so one of the discussions I had is one of the comments basically from one of my colleagues in Al-Razi is like, why? Because when I do these osteotomies, I drill with a 4.8 drill bit. They say it's like it creates a big gap at the osteotomy site. So this is an example of how they heal. They heal very well. All right, if you know the principles, if you know how to do a low heat generation osteotomy, they will heal very well. All right, and the osteotomy at the tibia also healed nicely. So the take-home message of this talk, I want you please to perform a basic, complete physical examination of your patients with patellar instability and patellofemoral pain. This problem, the rotational problems, are very underdiagnosed, and we always miss them. So please, if you see, just do range of motion, all right, or see how they walk. If you're suspecting abnormal hip range of motion, abnormal gait, any alignment problems, please refer them to the limb deformity clinic. Thank you.
Thank you, Dr. Youssef, for this talk. Any questions for Dr. Youssef regarding osteotomies? Please, in the back. Badr Hindi, Dr. in the back also.
بدر لازم تسأل أنت.
Dr. Najjar, And Dr.
شلونك شهوارك؟
تمام سلمك.
So your approach is very interesting. It's the same what we do for in towing, the same approach for examination. But I want to ask something you do in TROP. So you put the K-wires to correct the angles, but how do you measure the angles with the K-wire?
Again, I'll go back quickly just to show you the picture so you understand what I do. So I have a good picture from the first case. Sorry. Yeah, so see this. So I have a sterile goniometer. All right? I put the proximal K-wire at the level of the lesser troch posteriorly, away from where I'm going to put the nail. Then for the distal wire, I hand the goniometer. In this case, for example, 15 degrees, I just hold it, stand around the patient foot, and the center of the goniometer, this part is at the center of, imaginary center of the middle of the bone. And you try to place the second, your assistant or whoever is helping you, place the second wire distally, and so that you create a 15-degree relationship between the two wires based on the goniometer you have.
So it's eyeballing.
It's not eyeballing, it's goniometer based. It's not eyeballing.
Doctor, in the back there is a question from Dr. Muhammad. Turn it on.
Thank you.
تأخرنا دكتور نجار بسرعة أسأل.
Okay. Thank you, Dr. Yusuf. Any delayed union or non-union, some femoral osteotomy in your cases?
Any case you do, any surgery you do, you should expect complications. Yeah, they happen. Of course, they happen. But if you apply the principles and if you have a good patient selection and if the patient is compliance, usually you rarely see it. And all these patients, I give them a cocktail of vitamins and calcium post-op for 3 months. Vitamin D, calcium, vitamin C, and usually I believe the most important thing is a proper osteotomy technique. If you do a proper osteotomy technique, you rarely see it. But of course, any osteotomy you do, it might end up with a non-union. This is one of the complications we write in the consent form.
How long to tell the patient the time can heal? If you have normal principle.
They heal very quickly.
6 months, 1 month.
Usually you see, usually at 3 months you see excellent amount of callus in the healthy, good patient. At 6 months, usually you see there is no basically gap anymore, or rarely you see a gap, a small shadow. But those patients are fully functional immediately post-op. There is no restriction except at the beginning, first 6 weeks of avoiding extreme rotation, internal, external rotation of the head. That's the only restriction for them.
Dr. Jarrah.
Thank you.
No problem.
Yes, Dr. Jarrah.
Thank you very much, Dr. Yusuf. Quick question. How much correction do you do acutely if you're doing a derotation for the femur compared to the tibia? What is your cutoff in terms of this is the maximum amount of adhesing?
So this is not very clear. You know, also when you talk about open wedge, closing wedge, what is the maximum correction you can achieve? This is not very clear. But at the femur and the tibia, if you do it in the middle at the shaft, not distal, not proximal, you can correct acutely. Even 40 degrees, you can correct acutely. All right. But the patients have to expect, if you do that much correction, they have to expect a lot of muscle cramps post-op, because you're going to rotate the whole muscle groups, all muscle groups. All right. So they have to be very compliant with stretching exercises post-op to relieve, even prepare them pre-op. If you do your osteotomy closer to the joints, rotation osteotomies, you will be limited by many things. Like the last case, the supratubercular osteotomy. You cannot rotate a lot. You know, all the knee stabilizers are attached there. Your IT band, ALL, whatever, MCL, everything is around, you know. So you cannot usually rotate that much, around 15, 20 degrees maximum probably next to the joint.
All right. I think last question because we are running late.
Just to make a comment on your on your delayed healing, because it's a transverse osteotomy, so the strain would be quite high. It's a high strain environment. So the important thing about that is that if you do a very stable fixation, so osteotomy technique is very critical, but stabilization, so you optimize the strain and provide enough stiffness for a transverse osteotomy, will reduce the chances of delayed union to really small.
Thank you, Professor Sharma. This is my fellowship. I learned everything I know about osteotomies from this guy. Thank you, Professor Sharma.
Thank you.
All right.
Okay, Yusuf, I have just a question for myself. If you have a patient with hyperlaxity and also antiversion, so he has both ligamentous problem and bony.
See, hyperlaxity is...
Do you do the osteotomy anyway, or
no.
you don't do the osteotomy?
Hyperlaxity, we don't do that. Hyperlaxity, they will have extreme range of motion on both sides. So it's not really, even if they have a bony problem and on CT, which I will not do anyways for these patients,
okay.
I wouldn't care. Hyperlaxity, treat with as much as you can with physiotherapy only.
Thank you. So, thank you, Dr. Yusuf, for this talk. Unfortunately, Dr. Shakir has medical emergency. He's admitted in the hospital. He cannot do his genetic talk. We'll move to the last talk of this session, which is the role about social media and ethics, will be given by Professor Dr. Sami Al-Drai'i from the Law Faculty, كلية الحقوق. We chose this topic because it's really important for us. We see a lot of social media nowadays with doctors showing their patient moving post-op and the patient not tying the gowns, his private parts exposed, and he was not consented for the video. So we see these problems. This talk will be in Arabic, so we'll move the gears to Arabic. So رحبوا معي بالأستاذ الدكتور سامي عبد الله أحمد الدريعي، الأستاذ بقسم القانون بكلية الحقوق. دكتور سامي هو كان العميد مساعد لشؤون الأبحاث والدراسات العليا في كلية الحقوق من 2000 إلى 2014 لمدة 4 سنوات، وهو العميد المساعد لشؤون الطلبة بجامعة الكويت. قام بأعمال رئيس قسم القانون الدولي بكلية الحقوق ومستشار وزير الأوقاف والشؤون الإسلامية. أهلا وسهلا فيك دكتور سامي و thank you for your coming.
بارك الله فيك. بسم الله الرحمن الرحيم. يسعدني أن أكون بين معية أبناء وطني وعصارتهم الذين لا يؤلون جهدا في أن يطوروا العمل الصحي في دولة الكويت، والشكر أيضا موصول لرابطة الجراحين الذين سمحوا لنا بأن نطل عليكم بهذه الإطلالة السريعة. عنوان مداخلتنا اليوم هي وسائل التواصل الاجتماعي وأخلاقيات مهنة الطب في القانون الكويتي. حقيقة الحديث عن الإعلانات والتواصل الاجتماعي ضمن نطاق العمل الطبي يحتاج منا إلى أن نحدد نطاق هذه المداخلة أو هذه المحاضرة، على اعتبار أن أي عمل طبي أو أي تدخل جراحي أو حتى أي إعلان عن أي منتج أو مستحضر طبي يمس صحة الإنسان له آثار سلبية على المجتمع وعلى صحة البشر الذين يعيشون في هذه المعمورة. لذلك هناك قانونان، أو بالأحرى قانون ولائحة. القانون رقم 70 لسنة 2020 المتعلق بمزاولة مهنة الطب يحدد لنا الحقوق والواجبات بشكل عام للأطباء والمنشآت الصحية وما ينبغي على الطبيب أن يلتزم به، وأشار إلى ما يتعلق بالإعلان عن الأعمال الطبية وعن المواد والمستحضرات والأدوات التي يمكن في يوم من الأيام أن يتم الإعلان عنها في وسائل التواصل الاجتماعي. كذلك أيضا مؤخرا صدر قانون رقم 87 لسنة 23 جاء ليضع لنا ضوابط تتعلق بكيفية تنظيم الإعلانات المتعلقة بالأعمال الطبية وكل ما يتعلق بالمواد والمنتجات والمستحضرات وغيرها من المواد التي يمكن في يوم من الأيام أن يتم الترويج لها. لذلك يجب علينا أن ننظر إلى هذا الأمر من خلال هذين التشريعين. لا شك بأن اللائحة صدرت حديثاً، وبالتالي التساؤل يطرح أنه هل يمكن أن تطبق منذ صدور القانون أو أنه ينبغي أن تطبق من تاريخ إصدار هذه اللائحة. لا شك بأنه وفقاً لأحكام الدستور أن التشريعات لا يجوز كقاعدة عامة أن تطبق تطبيقاً رجعياً، وذلك بهدف حماية حقوق الناس وحرياتهم. لذلك فإن هذا القرار سيطبق من تاريخ نفاذه ألا وهو 12/3/2023. أيضاً نحتاج إلى أن نحدد من المعني بتطبيق هذه الضوابط اللي راح نشوفها بعد شوي. هل جميع المنشآت الصحية أم أنه هناك منشآت صحية خارج نطاق هذا التنظيم؟ في واقع الأمر المادة 15 والمادة 16 من قانون رقم 70 لسنة 2020 المتعلق بممارسة مهنة الطب والمعاونة لها وضعت قاعدة عامة تتعلق بمسألة ضوابط الإعلان عن أي منتج أو أي عمل أو أي دواء يمكن أن يروج للكافة. ولكن المؤسف أن القرار سالف الذكر في مادة 15 قد قصر موضوع الإعلانات وقصر نطاق تطبيق هذا القرار على الإعلانات الطبية في القطاع الأهلي فقط، وكأنه يخرج أي إعلان تقوم به المؤسسات الطبية التابعة للدولة، وهذا فيه تمييز غير مبرر في واقع الأمر، لأن الهدف من تدخل المشرع هو حماية صحة الإنسان. ولا شك بأن المستشفيات الحكومية هي أضعاف مضاعفة للمستشفيات الخاصة والمراكز الخاصة، فكان من باب أولى أن ينظم المشرع الإعلانات ووضع ضوابط لها الخاصة في القطاع العام والقطاع الخاص على حد سواء. الآن نبي نعرف ما المقصود بالإعلان وفقا للقرار سالف الذكر. المادة الأولى منه قالت لنا بشكل واضح بأن كل مادة أيا كان شكله أو محتواها أو نوعها يتم نشرها بقصد الترويج، يعني هني بقصد مهمة جدا، الترويج للخدمات الصحية أو أسعارها أو أي منتج أو علاج أو جهاز طبي أو مستحضرات أو خلطات أو تركيبات أو منشطات أو الأغذية الخاصة المؤثرة على جسم الإنسان، سواء تم نشرها من قبل مزاولي المهنة أنفسهم الأطباء أو ملاك المنشآت أو حتى من الغير، سواء كان ذلك بمقابل أو بدون مقابل. أما فيما يتعلق بالضوابط فلا شك بأن المشرع أراد أن يحمي المجتمع من انزلاق ممكن أن يحصل فيما لو تعمد بعض مروجي هذه الأعمال أو هذه التدخل أو الترويج لهذه التدخلات الطبية بما يؤذي المجتمع أو بما يعرض لسمعة أيضا المرضى وتشويه صورتهم. لذلك كل إعلان يجب أن يتضمن رقم الترخيص حتى يمكن مساءلة صاحبه. أيضا يجب أن تكون المعلومات الواردة فيه معلومات صادقة صحيحة تتوافق البروتوكولات الطبية، يعني مو أي معلومة توضع في الإعلان، وإنما يجب أن يكون هناك نوع من الأمانة العلمية. أيضا يمنع الإعلان ما يسمى بالوهن الطبي، يعني ما أي واحد يكتب أن أنا الأول، أنا المخترع الأول، أنا الأفضل، أنا اللي أحقق لك الضمانة الأكيدة بنجاح العملية، أو أن أنا مشهور لي في التعامل مع مشاهير السوشيال ميديا وغيرها. هذه الممارسات جميعها تعرض صاحبها للمساءلة القانونية. أيضا يمنع أن يتضمن الإعلان الطعن أو التعريض بزملاء الأطباء. يعني مو معقول أن أنا أضع عبارات في الإعلان من شأنها أن تمس من مكانة العلمية أو الأدبية لزملائي في المهنة. أيضا علينا أن نحافظ على خصوصية المريض وأن نأخذ موافقته كتابة، وأن لا نخرج عن الذوق العام، بمعنى إذا كنا هناك في حاجة إلى نشر بعض الصور فيجب أن نقف عند الحد الأدنى بما يمكن أن يوصل الفكرة المطلوبة دون الوصول إلى نقطة خدش الحياء. يعني ما يجوز بحال من الأحوال أن يتم عرض بعض أجزاء جسم الإنسان التي قد تثير غرائز الإنسان. كذلك لا ينبغي أن يتضمن الإعلان الأسعار أو وضع تسهيلات الأسعار. احنا والله عندنا تنزيلات، أو ممكن أنك أنت ما تدفع الآن تدفع بعد 6 أشهر. هذه ممارسات ممنوعة. أي ممارسة كهذه داخل المنشأة الصحية لا بأس بها، أما خارج المنشأة الصحية تجعل من صاحبها ضمن نطاق المساءلة. طبعا يستثنى من ذلك الحملات التطوعية، الطبية التطوعية. يعني ممكن أن الوزارة أو غيرها من تجمعات النفع المدني يرون بأنه هناك حملة تطوعية لمرضى نوع من الأمراض أن تقوم به بدون مقابل، فهذا لا بأس فيه، بل تشجع الدولة على العمل التطوعي. الإجراءات طبعا يقدم الرغبة في الحصول على الإعلان لدى إدارة التراخيص الطبية، وأن التراخيص الطبية يجب عليها أن تفصل في هذا الطلب خلال 30 يوم، ولكن القانون واللائحة لم يحددا النتيجة المترتبة على عدم الاستجابة لهذا الطلب، لأن في الغالب عند صياغة النصوص المشابهة يعتبر عدم الرد قبول، لكن المشرع في هذه الحالة لم ينص على ذلك. كذلك علينا أن نلاحظ بأن هذه المادة قد حصرت الشكوى المتعلقة بالإعلانات لدى إدارة التراخيص الطبية، وفي ذلك مخالفة صارخة لقانون ممارسة مهنة الطب، والقاعدة القانونية أن اللائحة يجب ألا تخالف القانون. لذلك هذه المادة من اللائحة هي مخالفة بشكل صريح وواضح للقانون الذي أعطى حق أو اختصاص جهاز المسؤولية النظر في جميع الشكاوى التي تترتب على الأخطاء الطبية والأخطاء المهنية. ولا شك في أن المخالفة التي تترتب على مخالفة ضوابط الإعلان هي مخالفة مهنية، ومن ثم يكون جهاز المسؤولية هو المختص في إجراء هكذا تحقيق. أيضاً المادة 37 بيّنت من الذي يقوم بالتحقيق وإصدار العقوبات، وهو جهاز المسؤولية، ولا يجوز بأي حال من الأحوال لأي جهة أخرى أن تصدر عقوبات، وأي عقوبة تصدر من غير جهاز المسؤولية تكون معرضة للبطلان لأنها مخالفة لأحكام القانون. أيضاً المادة 6 أعفت المنشآت الصحية العامة من الحصول على الترخيص، وذكرت بأنه مجرد إثبات المخالفة عليها تكتفي الإدارة بتوجيه التنبيه لها، وهذا ليس من اختصاص الإدارة، وإنما من اختصاص كما قلنا جهاز المسؤولية المدنية وفق المادة 37 من القانون ممارسة مهنة الطب. وهذا أيضاً من شأنه أن يعرض أي تحقيق أو أي عقوبة يتم الاستناد إليها فيها إلى هذه اللائحة إلى البطلان. الآن الإعلان في حسابات التواصل الاجتماعي، جميع هذه الإعلانات سواء كان فيسبوك ولا تويتر ولا غيرها من وسائل التواصل الاجتماعي تخضع لذات الضوابط اللي سبق وأن بيناها. طبعا لكل منشأة يكون لها موقع واحد في المواقع السوشيال ميديا، وأيضا لكل فرع أن يكون له كذلك، لكن ينبغي ذكر الأم وذكر كافة البيانات المتعلقة فيها، وأيضا لكل تخصص من التخصصات أيضا يمكن أن يكون لها موقع خاص فيها، لكن بجميع الأحوال يجب أن يذكر الأصل. بمعنى إذا أنت حطيت موقع خاص للمركز أو المنشأة وعندك أفرع، يجب الإشارة إلى المركز الأم. في واقع الأمر أنا عندي توصيات بأن ما أطيل، عندي كلام كثير كان ودي إني أقوله، خاصة أنه قاعد نتكلم عن قانون يتعلق بصحة الإنسان، ولكن حرصا على الوقت.
دكتور ممكن يعني نسأل الجمهور إذا عندهم مثلا واقعة صارت، يعني من الواقع، مثلا أنا الحين أقدر أبدي بشيء صار، أن مثلا دكتور أخذ إذن مريض شفويا، قال له بحط نتيجة عمليتي أنا بحسابي، ترضى؟ المريض قال له أوكي وحط. يا محامي شاطر قال حق المريض هذا أنت وقعت له أوراق؟ قال له لا. قال له خلاص روح اشتك ولك الحق تاخذ تعويض.
صحيح.
والمريض ممكن يشتكي يقول والله ما أخذ إذني، ويشتكي على الدكتور أنه عرض العملية من غير إذني.
لا، اللائحة تقول يجب أن يؤخذ موافقته كتابة، ولا شك بأن موضوع الموافقات الشفهية تدخلنا في دائرة جدا ضبابية، وهو الإثبات. هو سيدعي بأن الطبيب ما أخذ منه موافقة شفهية، والطبيب يدعي بأنه هو أخذ منه موافقة شفهية. كيف يمكن أن يتم إثبات ذلك؟ لذلك الكتابة هي دليل.
فممكن يكسب القضية المريض.
طبعا طبعا، لكن هذا ليس له ثمة علاقة مع الخطأ الطبي. يعني هذا يكون له الحق في الصورة، لأن أي إنسان عندنا يتمتع بحقوق إنسان، وهذه الحقوق منها ما تسعى إلى حماية جسد الإنسان، ومنها ما يسعى إلى حماية شرف الإنسان وكرامته. والحق في الصورة هي جزء من هذه الحقوق التي تسعى إلى حماية الإنسان في كيانه المعنوي. لا يجوز لأي إنسان أن يأخذ صورة لآخر دون موافقته، ما يجوز تحت أي ذريعة كانت.
في أحد عنده يعني شيء مر عليه قصة أو شيء بياخذ رأي القانون أو رأي الفني من الأستاذ؟ في هني in the back. دكتور بدر بعد.
يعطيك العافية دكتور. نفس السؤال، إذا في حال كان المريض نفسه يعني خلال التسجيل واضح أنه هو قابل أن ينشر المحتوى هذا، يعني واضح أنه يعني عن طريق الحديث ونقل المعلومة مبين أن المريض راضي، فشنو ما يعتبر هذا إثبات أن المريض راضي في نقل أو نشر الفيديو؟
اللائحة الضوابط تقول يجب أخذ موافقته كتابة. كتابة.
يعطيك العافية.
يمكن يقول أنا محرج كنت من الدكتور أو
لا تبرير، لأن النص واضح، الكتابة كتابة، ممكن يتحجج فيما بعد.
بدر، دكتور بدر.
عندي سؤالين بس دكتور. معك هني دكتور. معك الدكتور بدر الهندي.
ما شوف ترى دي. تفضل.
أنا طبيب عظام في مستشفى جابر، وأغلب هني أطباء عظام.
يا أهلا فيكم.
سؤال في موضوع أنت حددت الإعلان في نص القانون، وحددت أن المادة تقول لازم كتابة. إنزين، إذا أنا وضعت صورة هي لمريض، صورة أشعة، لا يمكن أبدا الاستدلال في أي طريقة من الطرق أن هذا هو المريض.
لا شك إذا كان مثل ما تفضلت بأنه لا يمكن الاستدلال بأن هذه الأشعة تعود إلى سي من الناس أو صاد بالناس، لا يمكن أن يثبت الخطأ بالنسبة لك.
زين انا قصدي ما اخذت الموافقه كتابيا وحطيت
كيف
صورة.
يستطيع هو ان يثبت ان هذه الرجل رجله؟
وهذا السؤال، لان هذا هو الدارج عندنا. الدارج عندنا انه ما يتم تصوير.
احنا نتكلم اذا الصوره انبأت عن شخصيه الانسان، لكن اذا الصوره لا يمكن من خلالها ان يعني يتم التثبت من شخصيه الانسان فشيء طبيعي، انت في مأمن.
يعني السؤال هو تعقيب على نقطه الدكتور علي، ان في نوعين من انواع الجراحين. احنا لما نعرض في السوشيال ميديا احيانا يعرض المريض وهو يمشي، فاعتقد ان هذا اجباري يكون في كتابه، ولكن اغلب الجراحين هني يحطون بس صور اشعاعات، وصعب جدا يعني تكاد يكون مستحيله انك تستدل من الشخص هذا اللي في الاشعه هذه.
هو الاشكال كله اذا صار نزاع بين الطبيب وبين المريض، المريض يدعي بان الطبيب ما اخذ مني الموافقه كتابه، تمام؟ الطبيب يقول لا انا اخذت منه موافقه، راح تصير مشكله بالاثبات. لكن اذا جاء وقال هذه ريلي، زين كيف يستدل المدعي؟ لان القاعده ان من يدعي شيء يجب عليه اثباته، تمام؟ فكيف هو يقدر يثبت بان هذه الصوره صورته؟ صعب شوي.
انا هذا النقطه اللي تعقيبا على،
لان الموضوع اثبات، الموضوع اثبات.
ثانيا، هل في نقطه مهمه جدا يعني اهم يعني تخفل على الاطباء في موضوع الكتابه، في الكونسنت مال العمليات مكتوب الموافقه على اخذ الصور، التصوير الفوتوغرافي. هذه مو هي المقصود فيها كتابه. لازم في الكتابه في الكونسنت لازم حق التصوير الفوتوغرافي لازم تكتب انت ليش قاعد تصور، وانت بتحطه بالسوشيال ميديا او بتحطه في ريسيرش
الغرض منها. نعم
بالضبط. اذا ما حطيت شنو الغرض منه مالت الكونسنت ما تعرف منها.
مثل ما تفضلت، يجب تحديد الغرض من هذا التصوير ومدته. يعني ما يصير انت تصور المريض وتقول لك ان هذا راح اسوي لشغله معينه ثم بعد ذلك انت تقوم بعمل اخر. وهذا جرنا هذا الى، يعني انا عضو من يمكن اكثر من 17 سنه بلجنه الاخطاء الطبيه، وبعد ذلك صار جهاز المسؤوليه. فنعاني بشكل كبير ودائم بعدم التدوين. يعني بعض الاطباء اما بسبب الاستعجال او الغفله او النسيان ما يكتبون، وبالتالي تصدر عليهم عقوبات.
اعتقد جزء كبير من الموضوع هي قله التوعيه صراحه. يعني جهاز انا
او ان انتم او انكم انتم يعني تضغطون على الوزاره تشوف لكم جهاز تتحدث فيه وهو يكتب بالسيستم.
الموضوع مو صعب، هي يعني اهميه الكتابه، مثلا موضوع الكتابه في الكونسنت او شنو ينحط في الكونسنت. انت من توظف ترى ما تاخذ اي تعليم في الموضوع هذا. انت لما تصير استشاري في وايد نقاط في القانون او قانون مزاوله المهنه ما حد شرح لك اياها. فعني انا الوم الوزاره بشكل كبير في الموضوع، ان هذا لازم يكون ضمن التدريب الطبي في اول سنه.
لا انت لا تلوم وزاره، لان انا اقول لك شيء. عندنا مبدأ في علم القانون، لا يجوز الاعتذار بالجهل بالقانون. الكلام هذا ترى ينطبق على كل المهنيين، يعني على المدرسين، على المهندسين، على الصيادله. يقول والله كليه وزاره التربيه والله ما شرحت لنا قانون المعلم. مال الصيدلاني يقول والله الوزاره ما فيجب عليك انت ان تعرف القانون حتى تتفادى النتائج الضاره اللي ممكن ان تصيبك.
بس احنا في حالتنا مختلفه.
شلون؟
في حالتنا احنا مختلفه حسب قانون مزاوله المهنه. الوزاره هي اللي تامنك حتى توفر لك تامين. الحين في الوضع الحالي الوزاره هي المسؤوله عنك بكل اخطائك وممارساتك، اذا نتكلم عن موظف حكومي. انا
بس معرفتك انت لازم، يعني بمعنى اليوم اذا انت ما واكبت التطور وارتكبت او سلكت طريقا اصبح من الماضي طبيا تؤاخذ.
تمام، بس ما هي الجهه اللي اروح لها تعال علمني القانون؟ لا يوجد. ما في دورات.
الدورات انت تطلبها تدفع فلوس عليها؟
ما في. من يسوي؟
انت.
انا اسوي دوره.
انت وغيرك من الاطباء تقولون حق الروابط وتنظم لكم دورات.
بس القانون وايد كبير. انا شايف القانون ايش كبره، يعني قال لي مليون مره وايد متعب القانون. يبي له دوره مكثفه يعني، ويبي له دوره منظمه. الدوله مو قاعده توفرك ولا قاعده تساعدك في الموضوع.
عليك تساعد نفسك، لأن إذا وقعت في الخطأ أنت من تعاقب وليس الوزارة. الوزارة مثل ما تفضلت مسؤولة عنك في التعويض فقط، وأنا كنت ممن صاغ القانون يعني، وتعمدت أني أضيف حماية كبيرة حق الأطباء لم ولن تحصل لأي فئة من فئات المجتمع الأخرى. يعني وفرت أمان كامل للأطباء، سواء عن الخطأ العادي أو خطأ غير المغتفر. هذا ما صارت على مستوى الموظفين العامين بما فيهم القضاء، ما في. لكن المسؤولية التأديبية أنت من تحملها. اليوم إذا ارتكبت خطأ عن جهل بمعلومات أو خطأ بجهل باللوائح والقوانين، تصدر عقوبات ضدك أنت وليس ضد الوزارة،
ضد الجمعية الطبية.
سوينا دورات ما حد يعرف.
دكتور بدر الأمين العام للجمعية الطبية للأطباء، فمتكفل فينا هنا.
سبق أن الجمعية سوت دورات، بس الأمانة حضور الدكاترة كان ضعيف، لأن الدورة يوم واحد ما تغطي القانون. تبي لك دورة يعني لازم تكون مركزة على التخصص.
صح.
لأن يعني كجراحة مو نفس كباطنية مو كمستوصف.
لا، هو يفترض البيسك القاعدة الدورة تكون بالقاعدة. ترى فيما يتعلق بالتخصصات هذه موضوع خاص جدا، خاص جدا. يعني القاعدة واحدة في كل فروع الطب، في كل فروع الطب.
الأخطاء تصير في الإشارات تصير هذه.
بالتخصص أشياء التخصص احنا مر علينا، يعني احنا قاعدين نشوف العيون ونشوف العظام ونشوف الجراحين ونشوف الكل.
شكرا دكتور. I think we'll conclude this session. يعطيك العافية دكتور حضورك ومشاركتك معنا في المؤتمر.
بارك الله فيك.
بس في شوية تكريم للأساتذة.
دكتور حمزة لاري. وعلي دكتور علي زياد. حسن بهبهاني دكتور حسن بهبهاني.
يوسف مروان.
دكتور يوسف مروان.
علي ذياب مشى بعد.
ايه يمكن مشى.
علي انا اوصل له.
ما عندك مايك تبي مايك؟
شكرا للحضور. نشوفكم ان شاء الله باكر في ورك شوب اللي يحب يحضر اوتسايد ان شاء الله بعد الكوفي بريك.